Good evening, everyone. I would like to welcome you to our April AABIP webinar. On behalf of the moderators, Dr. Siwei Lo, Majid Shafiq, and myself, Audra Schwalk. Before formal introductions, we'll go through a few housekeeping matters. First, everyone, please note that this webinar will be recorded. It, along with previous and future webinars, can be viewed on the AABIP website and can be found under the Education tab on the front page as shown here. So during the webinar, please note that the audience will be muted, so you will not be able to verbally interact with the speaker or the audience. However, you can certainly ask questions and communicate with the group during the webinar. All you need to do is type your questions or comments into the chat box or use the Q&A function. These can both be accessed by clicking on the chat or Q&A icons located at the toolbar on the bottom of your screen. Please make sure that your chat is directed to all panelists and attendees so that we, along with the entire audience, may see the question. We will keep track of the questions as they come up and address them toward the end of the session in a formal Q&A period, but please feel free to type in your questions at any time. So we would also like to reiterate that the AABIP does not endorse any specific technologies or products, and that also the content and views expressed within the webinar represent the opinions of the speakers and do not necessarily reflect those of the AABIP. So now that we got all of that out of the way, I would like to introduce our topic and speakers tonight. We would like to thank Noah Medical for sponsoring tonight's webinar. We're excited to hear about this important and very relevant topic. I'm sure that many of us in the audience either have a robotic bronchoscope or we're investigating the potential benefits of getting one for our patients and thinking about how we may integrate this into our programs. And knowing the best way to implement this technology in our programs for optimal benefit is really crucial to the success of robotic bronchoscopy programs and also providing excellent patient care. So our speakers tonight will discuss how to build a robotic bronchoscopy program from clinical, operational, and economic standpoints. So now I'll introduce our speakers. Dr. Krish Bhadra is one of our speakers. He's an interventional pulmonologist at CHI Memorial, who has really been a trailblazer in advanced diagnostic bronchoscopy and has recent publications on this topic that I think will really help us better care for our patients with peripheral lung lesions and advance the field of IP. And he's joined tonight by Dr. Stephen Kovacs, who's an advanced bronchoscopist and the chief of pulmonary medicine at the University of Pittsburgh Medical Center. He was the first in the United States to utilize robotic bronchoscopy and has also served as a strategic consultant for a diverse range of medical device, biotechnology, and software companies. So we are very excited to have both knowledgeable individuals here with us tonight to speak on this relevant topic and for the discussion that will follow. So with that, I will hand it over to y'all to begin.
Thanks, Audra. So yeah, and thanks everyone from the AABIP for allowing us to come in and speak about this topic. This is one of my really favorite topics to talk about, although it seems a bit daunting. It's always the how do you build the perfect program in 20 minutes or less? And we're not going to be able to get into the specifics of every single program and every single way to do this, but we want to go through the framework of this because as you know, to be in this room and listen to this, and you understand the broad impact of lung nodules. But every time I review it, it always still catches me on how many nodules are out there and how crucial it is to be able to manage them appropriately, both from beginning to end. So we want to talk about the basic framework and structure of what to look for when you are building a lung nodule program. And then also where the benefits of the NOAA Galaxy and being the first of its kind of a fully image integrated robotic bronchoscopic platform right out of the box really does play a huge role in dealing with managing your program and building it forward. And then we'll talk about the business case of this as well, about why this makes a lot of sense when you're adding this into your programs. You know, I think we kind of look at the numbers of over 1.57 million nodules found in the US every year, but to break that down to table stakes, you know, 1 of every 500 chest x-rays deals with a nodule, and 1 of every 100 CT scans within the United States every year finds a nodule. But the problem is when you look at national statistics on this, only about a little over a third of these lung nodules actually undergo full workup. Either missed at the time of diagnosis, people don't follow up, or just there's no pathway in place to really mobilize the ability to work these up and move this along. And then what we find is increasing populations with regional and distant disease years after nodules were found or should have been looked for. which puts patients in a very precarious spot. But when you deal with nodules, not everyone is malignant. And there's always this fine balance of what do we do with these? Because, we have the vast majority of these nodules we do find are benign. And we don't want to do unnecessary procedures, no matter what that is, because we don't want to take on a risk if we don't have to. So being able to prioritize patients in that methodology is important, but also we know that the sooner we intervene on the appropriate nodules, that survival rate is much higher. So we want to catch these as early as possible. You always want to catch these when they're Cheerio size and not the banana size. And what's interesting to me, when you start looking at time and not just capturing them, but capturing them quickly and efficiently, does change the paradigm when we're dealing with these nodules. When you look at the data coming across, the probability of malignancy is correlated with time of diagnosis. And what's as quick as our programs run, what scares me when you look at the national average time to just diagnosis, not even to treatment, is anywhere from 25 to 53 days. And this occurs for multiple reasons. This occurs because there's no workflow in place. The technology, patients requiring repeat biopsies, people are not undergoing appropriate workup, or just being lost in the shuffle. And when you deal, where this is worse are in patients and in centers that really lack true lung nodule management programs. Because as we know, again, early diagnosis saves lives. Your 5-year survival dramatically changes in 1A disease, especially very early 1A disease compared to stage 4 disease. With even advancements in surgical resection too, they always do better with in earlier stages. But even beyond just survival, you start to reduce things like hospital visits. You minimize nosocomial infections. You're improving patients' ability to stay at home, live their lives, not have to deal with the chronic care of later stage lung cancer and all the comorbidities that go with it. And not only is it most important to save lives, it also improves treatment costs. The earlier we find these and manage these, actually improves that cost. Now, surgical resection will have an average reimbursement of about $41,000, but that's an initial cost. A lot of that cost happens up front and much less throughout this course of the patient's disease. Whereas stage 4 disease, you start dealing with anywhere, usually on average, about $21,000 per month in total healthcare costs, which is a dramatic burden to the system and to the patients and everyone really involved with this. So the goal of this is to, or in earlier stage disease, we want to reduce both direct and indirect costs, moving that forward. So why do we have so much trouble with this? Well, these nodules are, as we know, variable in many ways. Patients are asymptomatic. They don't seek care. We only screen less than 7% of all the patients we should be screening nationally. Even those that do get screened, many of them get lost to follow-up or they come in to the ER with the cough, shortness of breath and get their inclusionary CT angio and they find a nodule, but they feel better and they don't get followed up. You have variable risk populations. The majority of them are smokers. We still deal with non-smokers that have risk factors of prior malignancies or occupational exposures or strong family histories. Classically speaking, when you deal with lung nodule management, it becomes single practice management, in which case it tends to be siloed. So the patient sees their PCP, then they see the pulmonologist, and then they see, and then they have to go through a workup for that. So whether it's bronchoscopically, as it should be, but sometimes they have to go see an interventional radiologist or a surgeon, but there's no direct correlation. There's no movement of these patients throughout the system. And when you deal with all these level of variabilities, both from disease and process, you have limitations of technology. Up until recently, it's been very difficult to diagnose very early small lung cancer with any significant ability to have that reproducible and have that move that forward, because the technologies were limited by diagnostic yields that were lower than we want. And also we didn't have, a lot of places don't have proper workflows when you're dealing with diagnosed lung nodules. So really, as we look at this, we're going to take the bird's eye broad picture view. It really kind of comes down to 5 basic categories. One is nodule recognition. You need to find ways to mobilize these patients forward, but really make sure that we're capturing them, whether screening the appropriate patients and working through a robust screening program, but also having incidental uh, findings. A lot of places have manual tracking, which has a lot of limitations, especially when you deal with a place like mine that does over 200,000 imaging studies, not just CTs, but in general, a year in a single center. So manual tracking is very difficult. So having software solutions, whether that's natural language processing like Eon or other modalities, to really make sure we're capturing all these nodules. And once you capture them, they need filtered. They need moved through the process. So having a navigator and a team, sometimes even a team of navigators to do that. And that's not just pulling nodules out of a system, but it's also facilitating referrals, talking to the PCPs who may not know how to order a lung cancer screening CT, and having the ability to educate them and really be that patient liaison. If somebody does have a nodule and they call in and they're nervous about this, we can mobilize them quickly. They're not getting stuck in a queue and being triaged with a lot of other disease processes. We're bringing them in and dealing with them quickly. And all these nodules we find, then it's figuring out the right pathway. Who can we watch? Who do we need to biopsy? We've utilized things like lung nodule calculators, which all have their benefits and limitations. We've pushed a lot toward biologic risk stratification. So using things like biodesics, using Notify to help us try to figure out which nodules are riskier than others, and trying to make sure that we're really honing on the ones that are of that moderate to high risk that we can really do the best for them. And then but the biggest piece of this too that is always problematic is diagnostic efficiency. You can capture every nodule you want, but if you're not diagnosing the ones you need to appropriately and quickly, we've not done a service. And we've been limited to that with a lot of the early technologies. But utilizing Noah Galaxy for me and Dr. Bodger really has changed that paradigm of how efficiently and accurately we can move this along. And then once you are accurately diagnosed, making sure you're maintaining this multidisciplinary communication. We have to have direct pathways to thoracic surgery and oncology, direct lines of referrals so we can get patients in very quickly. So you want to mobilize them throughout this whole process. Because really, when you look at programs, even on the bird's eye view, we start to really bring this down to the nuanced nitty gritty, where you're dealing with not just lung cancer screening and incidental findings, but how to interrogate EHR and working with these radiology workflows. Because a lot of times radiology has their own processes that aren't always tying into yours. So having conversations with radiology departments. And I would say the biggest thing around lung nodule management programs is conversations. You're talking to referrers, radiologists, oncologists, surgeons, partners, making sure that patients have a direct message about where they go and how they move forward on this. And then again, working through the clinical judgment of risk models and malignancy and biomarker testing. And then the shared decision making, having the tools and the processes to have these conversations with patients. Not every patient's going to go through a procedure, and every patient wants one. You have other patients don't realize they need a procedure or would benefit from one, and educating them to help them make the best decision for them all become paramount in moving this forward. And then making sure that going through the insurance system, make sure the coverages are there, and dealing with these multidisciplinary, high risk but high complexity patients really help kind of maximize both the care that we're giving them, and then as well as the reimbursement that is necessary to continue that level of care, and then maintaining levels of intervention and follow-up. And really, this is where the bronchoscopic platforms become very important as the keystone, if you will, of how we perform these accurate diagnoses and make sure patients remobilize as quickly as possible. This is really where it comes, again, this lung nodule navigation, this beginning to end communication, both with the point of contact of referrals, with the patients, making sure that your lung cancer screening or reminders and guidances are going out, implementing protocols when necessary. So to make sure that everyone's on the same page, at least for lines of communication. We don't treat every nodule the same way, but we make sure we're offering the same efficiencies for every patient that goes forward. I think that's the important thing to realize when you are using protocols, is that you make sure those protocols fit the patients, not always the patients are being shoehorned into protocols. And that's where you start to lose. When that happens, that's where you start to you kind of lose patients in that shuffle. But again, and making sure when nodules are recognized, done in a real-time way, our navigators will will bring things to us in real time as they're getting them, so we can evaluate, make sure these patients are being seen quickly. And that can be done at any level. Like, you can be in a large system where much that can be automated. You could be in a smaller private practice and having a person that just understands and knows lung nodules and knows them well enough to know your practices and know your preferences. So if a certain criteria is met, they're bringing that to you in real time and bringing that to you so you can evaluate that and make sure that's moving forward. A lot of people that don't have programs, it starts with those simple steps. Just having the communication with your team to make sure they know that they're on the same page as you to help you see these patients as quickly as possible. And making sure they're managing all the providers involved to make sure they're scheduling these procedures, as well as facilitating communication moving forward. But again, all of this is important to capture, to organize, to manage, but to get and to find the patients that are the highest risk that you can do the largest benefit for. So higher risk lung nodules require accurate and efficient diagnoses. But the problem of that, when you look historically, is that has been difficult. So a lot of places come from the world of CT-guided needle biopsies. And up until the advancements of bronchoscopy, that was what was done versus a surgical resection. The problem we find with that is the time it takes to a biopsy to the time it takes to surgery really starts to change that management. And you can see stage shift just waiting for diagnoses and management. Whereas bronchoscopic evaluation, on average, done in programs that are, capturing and managing lung nodules appropriately, can happen as quickly as 11 days, or even quicker sometimes on average. And then having an accurate diagnosis and not having to repeat one. So it's not getting a non-diagnostic specimen. It's not having to send them to CT biopsy because the bronch was missed, or not finding the appropriate diagnosis backs this up. So that has been the issue up until recently. And we started looking at our evolution of diagnostic yield. It never was fantastic. I mean, it was better than before we had any navigation at all. When in the best of hands, you're diagnosing a peripheral lung nodule, a third of the time without any type of imaging or navigation or guidance with a standard bronchoscope. But even as technologies and navigation improved and changed and adapted, whether you're going from superdimension to Monarch to Ion, in and of themselves, all of the early and ongoing data in and of itself maintains about the same in that 60 to 70% range. Not where any of us want to be. We don't want to only diagnose 2/3 of lung cancer. But that maintained. When you look at the Monarch data that came out, our study included, I mean, we had a diagnostic yield of 69 to 77% in a multi-center trial when we first started this. We were able to navigate, got to where we need to be at almost 90% of the time, but that diagnosis didn't correlate. And that maintained in a lot of the studies going forward. And even when you look at the Ion data, just in and of itself, without any type of advanced imaging, it was anywhere from the kind of 70s to 80s. Still, nobody wants, and even if these definitions of yield are correlating exactly the same as every other study, nobody wants to diagnose only 4/5 of lung cancer. We want to grab as much as we can with this. But a lot of the Ion studies started to show that when you started to add in imaging, specifically cone beam, or 3D CT imaging, that starts to dramatically change. We start to approach the numbers where we want to see in that that low to mid 90% range moving forward with this. So really, imaging was the key when it comes to the platform, and using it with a platform that can really integrate that well. And why is that? Well, it comes down to really CT to body divergence. These nodules are never really where we think they are. And that's a problem with any platform with just navigation alone, whether it's EMN, whether it's shape sensing. Those scans are going to be different. Those nodules are going to be in a different position than where you thought it was initially. And all these changes in anatomy and changes during the procedure as well, whether it's from anesthesia considerations, whether it's atelectasis, whether it's pulmonary edema, all those things will start to change the way that where nodules are and affect our diagnostic yield and increase procedure time and not get us to the level of efficiency we want to get to. So when we kind of look at this, average diagnostic yield across the board without advanced imaging is in the 80% range. But Average diagnostic yield with advanced imaging, gets up to 91%, which is great. The problem is a lot of the existing technologies we had prior to this, it was two separate systems. You had a Monarch and something else, or an Ion and something else to get there. And those are two separate things that were above and beyond just the C-arm that you already had in your room. So it starts to change the paradigm with that. And that's where the cost issues would come in. And that's where the Galaxy system really has its sweet spot when you're dealing with this, is the fact that you have adequate imaging with really cool and lesion CT tomography. And I'll show you some cases. We have a couple of them to give you an idea of what this looks like if you don't have a lot of experience with it. But this is three-dimensional reconstruction using only a 2D C-arm. No increased radiation beyond it's a standard C-arm that's there. And we also have the benefit of augmented fluoroscopy throughout the entire procedure, confirming really tool and lesion in overcoming this CT divide divergence. The other big piece about the Galaxy system, which I think is really underappreciated, but super important, is the fact this is a disposable bronchoscope. It's a 4 mm outer diameter with a 2.1 working channel that you use and you throw away. So you're not dealing with increasing cleaning costs and those type of procedural issues that processing that increase the time for your staff. And we'll get into it in a little bit here. And it's a single card system. It's designed for efficiently integrating in small rooms. Those of you who came to visit me, I do not have a giant bronchoscopy suite. We have a cozy little studio, but this fits very nicely in there. It inboards with our C-arm, with our rebus, out to our monitors. It really has been able to integrate in our room in a very streamlined way without having multiple systems, multiple towers, large arms. It really is compact and extremely efficient and sleek when you're using this. So kind of go through a couple cases here. So to show you, so this is a patient I did probably within the first couple of weeks. This patient had this apical lung nodule sitting on the medial border of the right upper lobe, showing significant PET activity with this. And this is an area that in any platform can be somewhat difficult. It's a very apical turn. It's a very difficult place to get into. Plus, there's a lot of emphysema that I didn't want to start poking needles and pulling forceps in areas where I didn't want that to be. So as you're seeing here is the navigation platform and us driving that with an always-on camera that maintains visualization throughout the entire procedure to allow us not just for driving, but also to make changes and course corrections, even at the time of biopsy. And it's an added piece of data that's built in that you don't really lose throughout the procedure. You can maintain that. And as we're navigating into kind of the apical segment here in the upper lobe, I'm making kind of small micro movements and getting us close to where we are. And what the blue ball that you see there is that kind of classic nav bronch visualization. That's our target of where it should be based on the CT scan. Now, again, it integrates with the rebus we have. We see that I'm close. I'm a little eccentric, kind of where I thought I was, but not quite directly on target. So now, utilizing the tomosynthesis spin with just the C-arm, in about 15 seconds, you're seeing this rotational component that is gathering each one of these pieces of information from these images and then collating them together and reconstructing them in a CT-like way. So with 15 seconds initially and about a minute processing, we're not stepping out of the room. We're not dealing with a lot of that. We start to be able to scroll up and down these images, and we start to see our nodular density. And zooming in, you can see in comparison, these are the actual case videos to the CT scan that was there. Now we've corrected for where we know our nodule is because we're not guessing anymore. And now we maintain a level of augmented fluoroscopy. That'll maintain in any view, whether and you have a great eccentric to concentric image there, I can now utilize this to help me biopsy. I can also get those images that your IR guys love showing, where you actually are showing your true needle and target. And I do this every time. And I do this without any really increased significant risk of radiation because, again, it's a 15-second C-arm spin. And once I'm in place and once I'm sure where I'm at, I can biopsy directly, maintaining augmented fluoroscopy throughout to ensure that I'm really getting what I need to get. And this is a level of confidence that I really didn't have with any prior technology because I wasn't able to confirm where that nodule was in that moment. And utilizing selectivity, we can see there's a lot of highly active cells. It was consistent and positive for malignancy. And then to show you one more case here is I want to really kind of dial in, we're dealing with CT to body divergence. So this is a patient that had this 15 millimeter, 17 by 15 millimeter nodule, apical, left upper lobe, but also had a pacemaker in place. So I've navigated out, been a little bit of bleeding there, but I'm taking my radial and I don't see a nodule. I don't see a nodule in front of me. I run Tomo and I know where I think that nodule is. And remember, every platform is going to have this level of divergence. So I don't see any lesion here. So what I can do though, I do see a shadow from the pacemaker, but I do this again. Again, I'm not doing another large cone beam spin. I'm doing a C-arm spin. I do this over the course of 25 seconds instead of 15 seconds. So it gives even more data as I'm moving through this. And I'm able to have that spin. So I'm getting images that were clear up front, but can be augmented and adjusted upon with only small changes to how we do this procedure. So now spinning this back and forth, I'm starting to see, as I start to get a little closer, an area that looks a lot like the nodule that's on my CT scan. And by zooming in on that, I can now correct for that. So I'm telling the computer exactly where this nodule is. No more EMN, nothing else. This is now where I've decided this nodule is in real time. We've completed this tilt spin. And now where I thought I was to where I needed to go, I can make this directional change. And I can start to see something blurry on the camera, but there's something changing in front of me there. But as I'm now on this current target, and just for confirmation, put my real radial probe out, I found that little bugger that was trying to hide from me there. So now by reconstructing and moving from where I was to where I needed to be, I again have augmented fluoroscopy that maintains throughout the entire procedure. And I've said that a couple of times, but it is that important when you're looking at this and being able to show that where my nodule is and fine tune where my tools are going. I can line my needle up to exactly where I need that to be. And now I've got my tool and lesion target, which was another 15-second evaluation. Again, every tool can be passed through this. We utilize a combination of needles and forceps, and again, selectivity was consistent with the squamous, with malignancy, which turned out to be a squamous cell cancer. So really, I think when you think of a nodule program, I think this needs to be looked at as a multifaceted, comprehensive approach. It's not just about finding screening. It's not just about seeing you in the office. It's not just about doing the bronchs and just about treatment. It's everything. But if you have to look at this in a way that organizes best for you and what you can do and what you want to move that through. So this is between recognition and acquisition. This is dealing with navigational staff and the responsibilities of that program that's specific to your needs and your patient's needs. And really, and I can't stress this enough, moderate to high risk nodules need accurate, efficient, and purposeful diagnoses. That is really the mainstay of this. And that's where image integrated robotic bronchoscopy rises to the top. And for me, it's utilizing Noah Galaxy with, again, the C-arm I had in the room, with the ability to use this in every procedure, in every space, and having the ability to not have to go to my house to purchase increasing equipment as we're looking at that. So really, this is the balance to me of clinical excellence as well as true financial responsibility for patients in our system. So I'd say that, we've got the tools and then we've got the talent. But all this being said is fantastic. But really, the question comes down to is really, how am I supposed to pay for all this? And how do I convince my hospital to make all of this happen? So to that, I would like to turn this over to the eminent Dr. Badra to go through this process. And then at the end of his talk, we'd be happy to answer any questions you guys have.
All right, I'm going to go ahead and share my screen. Can you guys see this? Okay, so yeah, we're going to talk a little bit about the financial component, about how to build a program. And so when we talk about the business of bronchoscopy, there's really three fundamental components of a successful bronchoscopic program. One is upstream development, which you can see here, which is the lung CT screening and incidental lung nodule programs, so screening and IPN programs. That's upstream development. Then there's also the contribution margin associated with, in this case, image integrated robotic advanced bronchoscopy. But the procedure itself has a contribution margin. And then we're going to talk about the treatment and downstream revenue. So in this kind of captures how you have to look at this business model development for robotic bronchoscopy. So let's talk about upstream development. So I kind of mentioned as an overview, upstream development refers to how do you identify lung nodules? And so really there's two models. One is lung cancer screening programs. And so we all know that the USPF task force has recommended high-risk patients undergo lung CT screening, but that's also been expanded. And we know that African Americans are included, younger patients are included. And there's also some discussion about including Asian American females who include into screening. So the good thing about lung CT screening is non-invasive and actually saves more lives than that of mammography, PSAs, and colonoscopies all put together combined. So we know that this is something that we have to invest in. But we also know that the adoption of robust CT screening programs takes some time. And so you have to build that over time, and that could be done with using EMR programs like EON or Think Health, or but you're also going to have you can also have buses, you can have mobile buses, and there's different models to be able to to increase your lung CT screening programs. The other aspect is incidental lung nodule programs, and that really accounts for the vast majority of lung nodule detection. And so radiology tagging with Fleischner guidelines, where it's already incorporated into the report to remind the ordering physician to consider appropriate physician consultation with a pulmonologist or appropriate subspecialty, further imaging, and the consideration of biopsy if it's appropriate for that patient. You also have to have a robust lung nodule clinic, whether that's a virtual clinic or brick and mortar nurse navigators, and you have to have role player buy-in. What do I mean by that? That means all of the key clinical players, such as radiology, pathology, oncology, thoracic surgery, administrators, all need to be part of that conversation and utilizing an EMR, like I mentioned. So upstream development is going to be extraordinarily important to be able to have not only, purposeful growth for lung nodule identification, also helping these patients clinically that a large portion get lost to follow up, but also that you have a good, smooth clinical pathway for these patients to be able to be incorporated into this business model. So when we talk about why would anyone need to have a robotic bronchoscopy platform, and the business case for Galaxy is that you get increased procedural volume. So I already do a very high volume of robotic bronchoscopy. And in essence, I have maxed out my time in the hybrid OR where I utilize cone beam. And so I needed a bronchoscopy platform to be able to grow outside of my hybrid room. And for those people who didn't have a cone beam, they needed something with advanced imaging to be able to increase their procedural volume. So we had a short trial for approximately 9 weeks, and then we were able to do additional 40 cases that allowed me that I wouldn't have been done because I didn't. Those cases would have been kind of take up time in the operating room in the hybrid OR. So you can increase procedural volume. And in this case, we didn't have to buy a second cone beam. We didn't have to, because I only have one fixed cone beam. You didn't have to spend a significant amount of money on mobile cone beam systems. You can use the C-arm. And if you have a mobile cone beam, you can use it with that as well. Now, this is a phenomenon called as halo effect. And say, what is halo effect is that if you imagine you're a primary care specialist and you have a patient with a lung nodule, and you want to send your patient to the best possible facility that you want your patient to get care for. And so if you think about it, it's the same thing with patients who have cardiac disease, right? Do you send your patient with cardiac disease that are high risk to a center that only has a CV surgeon, or do you send it to the cardiovascular team that has the ability to be able to do TAVRs, be able to do clips, be able to do full surgical interventions? So if I'm a primary care physician, I will send my patient to a provider that has the ability to be able to do robotic bronchoscopy, right? Because we know that you can have more precision, improve visualization, and there's an argument that there is increased diagnostic yield, especially when you add in advanced imaging. And What happens with the halo effect is that it enhances the overall image of the hospital, and it creates a number of competitive advantages compared to to hospitals that don't have robotic bronchoscopy. Certainly, it's going to increase the number of referrals as people recognize that you utilize this technology. And what's also nice about the halo effect is that the referrals may not be limited to lung nodules. And so as my program grew with robotic bronchoscopy, my major complex airways business grew, and so did my BLVR business grow. So there's opportunity for other complex pulmonary conditions to be sent to you and your partners so that you can grow your program. And then we talked about the procedure itself, and then we talk about downstream revenue. So we know that the percentage of patients with a robust lung nodule program with robotic bronchoscopy can cause a stage shifting where more patients are more patients are caught earlier in the disease process. And that means those patients can then undergo higher contribution margin procedures such as thoracic surgery or SBRT, stereotactic body radiation therapy. Thoracic reimbursement for surgical intervention can be in revenue, not contribution margin, can be as high as $41,000 per procedure. And so it's important that there's also a recognition, particularly with those patients that have stage 2B disease and higher, that they can have other injective therapies such as chemo and radiation therapy. So that's also important. So as your business and you capture more and more lung cancer, other downstream players benefit as well. Now, in terms of operational efficiency, so what's nice is that inside the Bronx suite, like Dr. Kovacs, when I'm not in my hybrid room, I work in a very small endoscopy room. And so I like the fact that I have a smaller robot platform that allows me to be able to kind of move around from room to room, and I'm not beholden to one room, I can move around. And unlike with a mobile cone beam, I don't necessarily need to step out. The radiation dose is nominal. And so you can just take a few steps back and then have the radiation technologist do your sweep, and then you can kind of move on. When I perform my cone beam sweeps, I actually have to leave the room. So there's some time saved there. And then you can also correct for CT to body divergence. And this is important because one of the most important aspects is with the tilt technology. And I think Dr. Kovacs will agree, is that the cognitive burden associated with the procedure is greatly reduced because the procedure is somewhat simplified. All you have to do is correct for CT to body divergence. You use augmented fluoroscopy, you check it in multiple planes, and then you just move forward. If your needle is in the blue circle and in the range of the the augmented fluoroscopy, then you're good to go. And you can confirm with another sweep if you want tool and lesion confirmation, but you can proceed if you feel confident that you're in a good position. And so you're not having, those, providers who struggle with integration with cone beam, we have to kind of wait for a 30-second spin, so on and so forth. So you save some time there, and you have this decreased cognitive burden that allows you to be able to move more quickly. And outside the bronchoscopy suite, so when I had, I used the Ion platform, and, we had a lot of what I would describe as hidden costs. We had to buy 2 Steris Endo 1 machines. We had to have a scope washer because we were doing such a high volume. And that takes about 1 hour for the scope washer to be able to process those scopes. And that resulted in a higher PAR, more disposable equipment. And it could take up to 34 steps to be able to process a single bronchoscope through the Ion platform and the Steris Endo 1 machines. And things like pre-cleaning, leak testing, so on and so forth. And so I don't have to do any of that. And that's actually really nice, is now when you utilize the Galaxy platform, you just open up your kit, you use it, and then you throw it away. You don't have to worry about that infrastructure. Now, disposable scopes also have the benefit of course, you don't have to worry about residual contamination. They have and reusable scopes have some element of cross-contamination of around 2.8%, and the average cost of treating an infection can go as high as $11,000. And so overall, the indirect cost per procedure for reusable scopes is around $330, and that gets mitigated. And so that's nice with the Galaxy platform. There's also a positive beneficial environmental effect. When you're using an ion catheter, we have to use approximately 5 liters of fluid, our normal saline or deionized water, or critical water is what they call it. And so we don't have to store so much water. So we don't have to clean it with and have vast amounts of water available. And so there's improved environmental impact. One of the other aspects is, and we don't really talk about this, is that when you have a reposable, every reposable bronchoscope will have some element of reduction in the ability to be able to maintain position. And I call this catheter drift. Catheter drift means that the catheter itself doesn't perform as well. And so you'll see it kind of move in position. So you have to spend more time correcting the actual location of the catheter. So you can hear as an ion scope with the needle out, pointing at the CT augmented fluoroscopy on a fixed C-arm cone beam spin, and you can see that just after a spin, the catheter had shifted position. So you have to kind of go back and forth. And if you're not mindful of this, this can render a non-diagnostic biopsy if there's substantial catheter drift. And so that's something that's nice. Every time you open a NOAA Galaxy catheter, it's brand new, like an iPhone. You know that your iPhone works better the first day that you buy it compared to 3 or 4 years later after much use, that you see a degradation. So that's really nice. And I think it's kind of one less headache to worry about. The FDA has also made a statement that disposable bronchoscopes should be used when there's an increased risk of spreading infection or there's no immediate support for reprocessing a bronchoscope. And this is really important because when we would dial down close to 6 p.m., and nobody likes to start, cases will finish at 6, 7 p.m. in certain facilities, and it's like a ghost town. And then what happens is that my staff would have to stay longer, and we would run into issues where we didn't have an immediate support for reprocessing a bronchoscope. So when those types of situations occur, this is a solution for you. So that's nice. The other aspect is the Galaxy bronchoscopes may qualify for a transitional pass-through payment. And this is CMS awards transitional pass-through payments, or TPT payments, to facilitate Medicare beneficiary access to new and innovative medical devices. And so a TPT code offers an incremental payment in addition to the standard Medicare payments that you would have related to the procedure. This was effective in January 1st of 2024. They allowed TPT status to qualifying single-use pulmonary bronchoscopes, and the Galaxy scope likely meets these TPT payments. And the status is set for about 3 years, and then this expires. So for a short period of time, for at least 3 years, this might be a good thing, especially if you're a high-volume center. You can get some added financial benefit for this. And so the code is C1601. Its device category is endoscope single-use pulmonary imaging and illumination device, and it has to be insertable. So there is a coding process, and I'm going to just kind of go this as an overview. And Medicare outpatient procedure is performed with eligible bronchoscope. Your claim has to be submitted along with the C1601 code, and you get the regular payment plus the TPT, or transitional pay-through payment. And so the way it works is that I'm going to go through this in a second, so I'm just going to walk you through the calculation. A device charge, then you have a CCR, which is cost to charge ratio, a device offset, which is attached to the code, to a particular CPT code, and then you get a TPT payment plus your complexity code payment, and then you get your total reimbursement. So that sounds like a lot. And for those of us who don't do a lot of billing and coding, let's give you an example so you can kind of see what I'm talking about. So this is an example illustrating what a transitional payment would look like. And so this would include, you have to have a complexity adjustment code for both CPT codes 31629, which is a needle FNA, and a 31628, which is a forceps biopsy for this illustration. So the hospital charges the C1601 traditional pass-through code and you can assign this amount, and you can assign a charge to the catheter, whatever you want it to be. So this is important to understand. But then there's a cost to charge ratio that the hospital assigns, and it's institution specific. There's variety of different ratios, but then 7,500 gets multiplied by 0.2689, and then you get this reported cost of with the C1601, and then you end up with the reported cost of the catheter. There's a device offset that's associated with the actual billable code that's associated with the complexity billing 31628, which is that forceps code, and that gets deducted, and so you end up with $1,972. And then you get what you would normally get paid, which is and this is a little bit complex, but 31629 was the F&A code. 31628, which is paired together, which is your secondary code, which is a forceps code. And then you have an APC adjustment, and that's 5155. And this is pretty standard for most providers, and this is your Medicare reimbursement. And what happens is you get your total complexity adjustment, your payment for Medicare, 6528, and then you get the additional payment of the catheter itself. And then the total payment is 8,500. So that gives you an idea of how that works. So in summary, when you're looking at trying to make a case for and you're trying to build out the correct model, there's multiple different aspects, and diagnosing lung cancer has both clinical and economic benefits, but it's complex, patient specific. You need to have an integrated lung nodule program. You need to have the actual technology to be able to kind of correct for CT to body divergence. And when you integrate a very well-developed lung nodule program with upstream development, a procedure that makes it with decreased cognitive burden, you don't have the additional cost of advanced imaging equipment, and then you marry those two together, and then you have a very good business case for the Galaxy, where you can just use existing imaging technology, and you can have the benefit of having a robotic bronchoscopy platform without having the hidden costs of reposables, and you have the advantage of having a disposable scope. So I'll close here and let you take over for the moderator section.
Thank you very much, Dr. Kovacs and Dr. Butler, for this excellent review. It is both fascinating and very encouraging to see how this field continues to grow. Of course, patients and other providers alike continue to look to us for helping move the needle in terms of making diagnoses more effectively, more safely, and more reliably. We have a number of wonderful questions, some in the chat and Q&A section, some that were submitted during the earlier registration for the webinar as well. May I ask one of you to perhaps comment on, if you happen to know, sort of the quantitative amounts of radiation that are involved with this, 2D tomosynthesis. One of the commentators mentioned that according to some literature, the total dose for cone beam CT scans have also decreased to, they gave a big range, and I'm more comfortable with millisieverts, but this is in milligray, 12 to 50 milligray average. Would 2D tomosynthesis be much lower than that? What would you say?
Well, so it's really difficult to compare volumetric radiation. And so traditionally we use a dose area product. And that can be converted into a DAP dose, which is milligray divided by the volume. And so each provider, whether it's GE, Siemens, or Philips, will report a different unit. So let's just start there. But let's say you were to have a perfect world, right? So millisieverts versus milligray associated with like a 2D fluoro platform. So one is volume radiation, and one is a linear dose like 2D fluoro. So it's really hard to compare But it's safe to say that cone beam systems generate more radiation. So that's obvious. And then there's going to be radiation associated that you would have normally done anyways with 2D fluoro, even if you had mobile cone beam or a fixed cone beam platform. So inherently there's less dose, and certainly there's less dose with a linear sweep from the tilt protocol, because it's only 15 to 30 seconds max. So there's going to be a substantial dose reduction. When I perform cone beam, I leave the room during the sweep. When I'm doing digital tomosynthesis, I stay by the patient because I feel comfortable with the radiation dose associated with digital tomosynthesis.
Great, thank you. One question that I think both of you sort of spoke to a little bit, but it would be worth sort of expanding on a little bit more, is the ultimate practical question. Fine, we loved what you had to share. The data seems convincing. We're sold. Now, how do we sell this switch from one robotic platform to another to the administration? What was your experience like? What tips, what pearls and pitfalls could you share with us?
So for me, how we did this was we had a really a conversation based on the history of the platform we had before, which was the Monarch system. We talked about kind of its benefits and what it brought to our market, but also a bit of its limitations about where we found over the years of having some difficulty in improving our diagnostic yield past where we were before, not having the ability to conform to CT to body divergence, and that in order to do that, we'd have to look at purchasing other equipment, and where could that be? What does that strategy look like? So for us, once we had that conversation, we started looking at the options out there. The Noah Galaxy really is what kind of came to the forefront, because it allowed for my hospital to have a cost that was going to be similar to what we were spending on Monarch. This is even prior to TPT, which even made that better, but also the fact that we could use the imaging equipment we had, within a system as large as ours. It's hard to buy things like even cone beams and COSs and NX, things like that, especially when you're trying to mobilize that. So having the ability to improve our accuracy, again, minimize having to do multiple different procedures and the ones that we missed, but also really being able to have these patients move through in a very accurate, again, meaningful way with just a variation of robot, but no other variation of radiographic workflow than our C-arm. It made sense to the system. So we're evaluating, they're constantly evaluating. We're looking at costs, but they have been pretty pleased so far with our first 7 months we've been using this, both from our clinical efficiency as well as the cost profile from what we had before. So,
yeah. So
thank you.
I think, yeah, I'll chime in. I think when you're having the discussion about how to switch platforms, I think it's a somewhat of a nuanced discussion. So what I would recommend is you go in and you make an appointment with the correct administrator. And in my situation, I went and spoke with the C-suite and directly met with them. And I said, I have a clinical problem. I have kind of maxed out my current volume and I want to be able to grow. And the main issue is that we can invest in a new platform that incorporates a low-cost, value-added solution with a lot of synergistic operational efficiencies, like we don't have to worry about scope reprocessing. We don't have to worry about catheter drift. We don't have to worry about having to purchase a whole nother platform like a mobile cone beam. And so it allowed us to be able to have the conversation about, well, how much do you think you're going to grow? We've certainly seen that robotic bronchoscopy has been helpful. And the conversation becomes about volume, new business, being able to still go after complex lesions with a value-added platform that reduces operational costs and can increase volume. And those are the and solves a clinical problem, right? So that's what they want to hear. I think they want to understand that you have an issue with the being able to mobilize and move patients through your lung nodule program. and you have to give them reasonable understanding. And it's a competitive market, so you're not the only service line that's asking for help. So you have to be able to speak that language. So, if you're really seriously considering, I would, go back to this slide deck and then go through it. But then go directly speak with the key administrators and gain alignment.
Thank you. And for all the attendees, just a quick reminder that a recording of this webinar with all the slides will be available on the AABIP website in due course of time. A few questions about the practical sort of workflow during a case. Either of you or perhaps both of you can chime in on this. How many needle passes do you typically do? What gauge needles do you use? What kinds of tools do you use for your biopsy as well?
So for me, I typically do a lot of just needles and forceps. So we use a combination of usually the lower gauge needles like the arc points or the Paraview flexes. I still use the Monarch forceps. I like them. They get good kind of good amounts of tissue. Really when you talk about the number, it changes. It kind of depends on the patient, depends on the nodule, depends on what we're finding. A lot of these eccentric nodules that I can localize, I may do a couple of needle pilot holes, if you will, and then slide forceps through the hole that I made because I can see it, I can line it up, I can see where I'm going with my augmented fluoro, make sure I'm matching that up in order to get that. We use also selectivity as well as part of our ROSE analysis, so we're getting pretty accurate cellular evaluation up front. So if I'm seeing a lot of pathologic cells in front of me, and I know I'm getting lesional material, that I may not need to do as many biopsies with that. If it looks like, I'm seeing inflammation with small areas of cancer, then we will do more of that. But to me, I think that, nowadays that we can really hone in on where we're biopsying and have that high level of accuracy for imaging, I think it changes the fact that, the tool and the technique, they tailor to the lesion, not so much taking a standard rote approach every time you do that. So that's the way we've been looking at it and change our paradigm from that now.
I think it's a great question. Yeah. So I'll talk about at least how I approach it, and then kind of talk a little bit about the literature associated with it. So a couple of things we know for diagnostic yield, which is in and of itself, a conundrum. But let's say we're going for strict definition and we really want to do the best job that we can. We know that based on the Navigate study, based on Verhoeven et al., when they looked at their cone beam data, and recently published a paper for ultra-thin cryoprobe, is that the more tools you use, the more likely you're going to have an improved diagnostic yield, which means if you use a needle, brush, forceps, cryoprobe in combination, you're likely to have an additive benefit. There's a couple of things that you need to understand. Histologic samples are better than cytologic samples with regards to diagnostic yield. And I would also encourage, if you're really trying to get as many biopsies as you can within reason for your patient, that you focus in on forceps. And if you have the ability to be able to use the ultra-thin cryoprobe, you should at least consider it if it's appropriate for your practice. And the reason for that is that there is actually an added benefit. Oberg has been able to show, because of the unique qualities of the cryoprobe, that you can get that 360 biopsy. So that's an added benefit. And my paper was significantly less, but I used cone beam in that case. And so that was around 3.6% improvement with the cryoprobe. I think the only tool that I think is kind of remains controversial in terms of its additive benefit is probably the brush. But I still do it anyways, just in case that there's an off chance that there might be some benefit. So I use kind of a structured protocol. But I would encourage to, get needles, get brush if you think it's necessary, and then focus in on histologic sampling. I think that's going to be really.
So what gauge needle would you, if I may ask you, typically use, and how many passes for the needle?
Yeah, so I use an arc point and a Paraview. I believe there are 21, if I remember correctly. So small thin needles, and really, and then the number of passes, typically, I do 2 slides, 6 cell blocks for needles, And then for cryoprobe, which I do next because there's less deflection associated with the cryoprobe, I'll do 2 and 6 for the block and 2 for touch prep. And the same for forceps. Bearhoven and said in this paper that once you get to around 16 histologic biopsies, that you'll have, kind of optimize your diagnostic yield. And I'm not sure if that's really true when you spread that across many different platforms and many different centers. But the idea should be, get as much tissue as possible. And I also think that there's another movement that's occurring in our world in terms of treatment. There's now a focus on neoadjuvant therapies for IO or immuno-oncologic agents. Neodora is coming out, so that's probably going to be published later this year, where you're going to want biomarker data up front. And so you're going to really want to focus in on being able to get histologic samples for molecular analysis. So I think that'll be also important, even for early stage disease, where we traditionally thought that was a concern only in advanced stage disease.
Thank you for these thoughtful answers, and thanks to the participants who are still with us. I know we are a little bit over the hour, but let me see if I can get in a couple more interesting questions as well. Talking about challenging cases, one of the participants talked about sort of the performance of augmented fluoro in visualizing GGOs, and Dr. Kovacs actually responded in the chat as well. He hasn't had a lot of issues visualizing them and has gotten the diagnosis made as well. In a similar vein, another participant asked about how many TILs do you need to typically perform in a patient with a high BMI or lesions that are really close to other anatomical structures, if you can speak about the performance of augmented fluoro for those challenging lesions, GGOs, proximity to other structures, patient with large body habitus and other similar scenarios.
So a lot of that up front comes with preparation. So, there's a lot of protocols that have kind of been written by Christian, Mike Pritchett, and a lot of guys that deal with anesthesia utilization. So we utilize recruitment maneuvers. We utilize breath holds. Many times we'll navigate even under a breath hold. We'll utilize, again, breath hold, the time of the TIL, time of the biopsy, as well, to help keep things immobile in order to do that. And those maneuvers really do help kind of move that forward. Even patients that are obese, many times you still visualize these areas. I haven't had, I'm trying to think there, and all the ones that I've done, there's been nothing really jumps out than the fact that sometimes you have a nodule that's just really close to another dense structure. Or let's say that we have to really kind of work with the anesthesia. There's a lot of atelectasis around an area, which is going to be difficult to see. Those ones sometimes will require a second tilt. I rarely do more. A lot of times the first tilt, because we do all these things up front, will show us where we're at. And then I'll get my tool and target image. So I like to have that kind of needle in target to reconfirm for me. So for me, I would say majority of the time I'm doing about 2 tilts spins, but every once in a while though, you do have one that you may have to do an extra one with, but it hasn't really changed. Again, our workflow and the radiation dose for just another C-arm spin has been so minimal for us. There has not been an issue on that too. Are you doing, Christian, about you?
Yeah, I mean, same kind of thing. Obviously, everybody, we're all familiar that I use the lung navigation ventilation protocol, which is a high tidal volume, high PEEP strategy with apneic breath holds. And so anesthesia setup is really important, and having a buy-in from the anesthesiologist and making sure that you optimize conditions for image-guided biopsies. And that goes for digital tomosynthesis and cone beam CT bronchoscopy. So that's going to be just across the board. So once you've have made that decision to be able to, kind of mitigate respiratory motion, reduce atelectasis, if you can see it, you can biopsy it, is the way I would put it. And so if you're, let's say you develop atelectasis, it doesn't matter if you have cone beam, it doesn't matter if you have digital tomosynthesis. You're going to struggle, and that's just the way it is. And so with digital tomosynthesis, the obvious things are, if you have to be smart about what the kind of the cases that you pick. Like when I go to my cone beam room, if a patient has a BMI of 50 to 60 in this range, I have to think, do I really want to do this? Because sometimes I have collision risk because if the patient has significant thoracic girth with the cone beam, and then you have to think if you're going to be able to even see it. And so those are what I would describe as case by case basis. You want to select cases, at least if you're starting to do really obese patients, is to kind of pick cases that make sense. And then see if, and then as you test the limit of what you can do as you go along. I think that's really like a patient-specific question. But the way I would think about it in all image-guided biopsies, make sure you think about an anesthesia protocol. Make sure you think about mitigating respiratory motion. At least consider if you feel comfortable with apneic breath holds like I do. And then make sure that you know that you're thinking about, will I be able to see this at the time of biopsy?
Thank you. And you continue to, just to confirm, it sounds like the answer is yes, but both of you continue to use radial EVIS in your current workflow as well. Yes.
Yeah. So radial probe, I think, is one of those things where it improves operator confidence, and I like confidence. So I like the added ability to be, I use the radial probe for two reasons, really. One is to be able to put out the radial probe and assess the trajectory of what the needle might be. So sometimes you'll, you know that the lesion is there, and then you'll push the radial probe, and then you'll see that the catheter veers off, or the radial probe veers off, and then you know, and then sometimes it gives you an eccentric view, sometimes it gives you a concentric view, sometimes you see nothing. But it does give you an image so you can have improved confidence, but it also gives you some information about the trajectory of your needle pass. And so I tend to use it every case. So I haven't kind of walked away from it. And but there is an argument, there is a controversy that's going to develop, because when you start to do tilt, you're going to realize, do I really need this? And so there will be some situations where you may not need any rebus whatsoever. I'm at this point where I'm not. That's a harder decision for me to make, and some old habits die hard. So that's kind of where I'm at. Kovacs, what do you?
I promise you. Sorry, go ahead, Dr. Kovacs.
No, I get real quick. I agree. I'm a measure 5 times cut once guy. So it's another added ability again. But yeah, there is that controversy. Do you I would say that if you don't have rebus, you don't have to get one to use this with tilt. If I already had one that I was using anyway. So to me, it was it just, like Chris said, an added comfort level. And I do like the fact of seeing where the trajectory of my tool is going to go. That does really kind of give me a contour of the nodule, even above and beyond, what we're seeing in Tomo and how I'm going to approach it. So, and it takes 2 seconds for us. So it's something we still maintain in our workflow.
Thank you. I promise you both, you're going to be pounded with lots of additional questions via email. So don't be surprised, because it's been so educational. But really, very quickly, I wanted to ask one last question, which was about any tips for managing bleeding complications when things don't go right for some of our unfortunate patients. Any tips, any elevator pitch kind of tips that you can give to our attendees to take home with them?
Yeah, I can. So it depends, right? So if you're having a significant bleed where you see the blush of blood on the screen in terms of the fluoro screen, right? And let's say you see that the screen, I always say that the screens go red rum, like they just all turn red. So the couple of things, if you start to see blood kind of coming back into the ET tube, or if you see it come out the channel of the catheter, one of the most important things is that we pre-mix topical. You can use leave fed. You can use also TXA. And so the nice thing about having the catheter at the direct site where you biopsied is you're going to be able to administer local medications at the site of bleed, right? So that's number one. And then you always want to have your therapeutic scope available in the room. And you should always at least have a plan as to how you're going to approach that. We always stock in our room, obviously we're going to have the therapeutic scope. So if we have to suction out a significant amount of blood, plane the bed towards so that side that was biopsied, the dependent side, is shifted over. And I may even move the patient in reverse T, just to kind of make sure that it stays dependent. And then we use all of our traditional methods to be able to balloon blockers and such. But I think one of the teaching points, if you're prepared and you have it ready, is that you can administer some medications rather than right away pull out the catheter and then switch out.
Completely agree. Yep, that's exactly what we do as well.
Amazing. Thank you once again, and over to Audra to close it up.
Thank you all again for taking time to speak with us tonight. It was an excellent talk, lots of information. I agree with Majid that you'll probably get some emails with additional questions. So we know you're busy. We acknowledge and appreciate the time it took for y'all to put this presentation together tonight and speak with us. We also want to say thank you again to Noah Medical, our sponsor for this webinar. This topic is certainly applicable to many of us that take care of patients with peripheral lung lesions. So thank you again. And also remember, as Majid said earlier, the recording for this webinar will be available on the AABIP website soon, and should also be available on the AABIP YouTube channel. So make sure you let others know they can also check it out if they weren't able to attend tonight, or if you want to hear it again. And thank you to everyone who took time to join our webinar tonight. We hope you can join future webinars and other endeavors from the AABIP. We'd like to remind you that if you're not already a member, please consider joining so you can take advantage of all the other things that the AABIP has to offer. And these offerings will include a new members only webinar series composed of a variety of topics, as you can see here. So make sure your membership is up to date, or you become a member if you're not already. I also wanted to put in a quick plug for the annual conference, as registration is now open. So make sure you register and see all the new offerings that are available for the 2024 annual conference. Because you won't want to miss those. And lastly, we hope you can join us for our upcoming webinars. Our next webinar will likely be in June at the usual time of 7 p.m. Eastern. So please be on the lookout for upcoming announcements with the specifics for that webinar. Thank you all again, and see you next time.
Thanks.
Thanks, everybody.
Thank you all.
Thank you.
Thank you.